So everybody in this room has basically gone to medical school or nursing school or some kind of professional school, and everything has changed since that time. It's totally different. I've been in practice 7 years, which isn't that long, right? And everything has changed in 7 years. It started when I was with Paul, and it's totally different now because the way we treat aortic disease is completely different, and you're going to hear about that tonight. One of the differences is the things that we consider now were totally irrelevant 10 years ago. And I'm going to talk about one of those topics, and that's the dynamics or the movement of the thoracic aorta in 10 years. And I'm going to focus it specifically on thoracic aortic emergencies, catastrophes. So traditionally, we used to do thoracotomies. So someone come in with a ruptured aneurysm. A catastrophe is basically a hole in your thoracic aorta. That's a fatal event. We used to fix that with these massive open surgeries where we'd clamp your aorta, potentially stop your heart, put you on cardiopulmonary bypass, sew in a graft, and they did terribly. The good news about that is they did so bad that we didn't have to do that well to improve upon it, and we've significantly improved upon it. And a lot of that work was done here in Connecticut with several of the people in this room. Shout out to Mike Sergi, who was trained at Yale. He did some of this work and certainly knows about this kind of information. So 10 to 15 years ago, we started using endografts for the treatment of these holes in the aorta, thoracic aortic catastrophes. There's no data to support it at that time, but the results were so bad with the open surgery, we decided that we should use this new technology to treat these problems. You couldn't do worse. That was our philosophy. So there was no data, so we decided to look at the data, and we did a multi-institution trial on ruptured thoracic aneurysms. You know what the mortality of a ruptured thoracic aneurysm is? It's about as close to 100% as you can get. So we decided to look at our experience and the experience of several centers that treat these ruptured thoracic aneurysms with stent grafts, a new technology at the time, and see how they fared. And we published this in Circulation. And you know what? They didn't do as badly as the open surgeries. So specifically, about 50% went on to have a freedom from secondary intervention. Now, I think that's a success. You could look at that and say, well, my God, 50% needed a secondary intervention. What that means to me is a great number of patients were alive to get a secondary intervention. So we saved their lives, but then they had problems later on. All right? So we fixed one problem, a life-threatening thoracic aortic aneurysm, and created another, an endoleak, a migration, a collapse, and so forth. So when we looked at our data, which was about 150 ruptured thoracic aneurysms over 7 institutions, and this was led by Yale, we could see that the occurrence of an endoleak was 17% within the first month. And this is an endoleak. You can see here this contrast coming outside the graft. That's an endoleak. These are all different kinds of endoleaks. Down here you can see contrast outside the graft. That's an endoleak. So we treated the rupture, they survived, and then they went on to have a very high rate of endoleaks, which is a problem. Not as big of a problem as being dead, but seriously a problem. So the reason that I think this is a problem is that we're looking at this in an old-fashioned way. We're used to looking at these ruptured thoracic aneurysms like the images that I showed you, but in fact we're putting these stiff, non-compliant, non-movable devices into an environment that is very different. And when we stitched them in 10 years ago, it didn't really matter because our stitches were stitched right in. But now when we're putting a fixed tube inside a aorta that looks more like this, and you can see this is my fellow's aorta, a healthy 20-some-year-old aorta, you can see that it changes with the beat of your heart. It's different. Now, if you were stitching it, it wouldn't matter. But if you just put a pipe inside of that, it potentially might matter. Well, does it matter? So you look, you know, these are stent grafts we put in. There's a lot of movement that's happening in the aorta. These are gated CTs, and this is work that I did in the Netherlands when I left the United States and went to the Netherlands to do a fellowship, and that's why I put the Netherlands symbol down here. These are patients that I treated. And how much does the aorta move? If you look at the aorta, how much does it move? Well, it actually moves about 10%, more or less, depending on where you're at. 10% diameter change. Well, does that really matter? So you look at something like this, right? This is a young, relatively young, a 31-year-old man. He swallowed a chicken bone. He perforated his esophagus, and then he perforated his aorta. He had a hole in his aorta. Sorry, this is dinner conversation. And, you know, he had all this blood coming out, and he was dying, and so we treated him with a stent graft. But you look at this. This is his left carotid, and you got a stent graft bouncing up and down. And this looks like a problem. This looks like a real problem, right? We treated his initial hole in the aorta, but this doesn't look like a good long-term solution. And you can imagine if you wait a little bit. This is another patient. This guy had a traumatic aortic rupture. You can see the pseudoaneurysm right there. See it pouching out under the aorta. This is basically a fatal problem. We treated this guy also in the Netherlands with a stent graft, and you can see the top part of the stent graft just collapsed. It collapsed. His pseudoaneurysm is still pressurized, and this is potentially a fatal problem. But if you watch as the heart beats, the blood squishes through right there. That's the only amount of blood that's supplying his whole body below his chest. So we put another stent in there, and then that collapsed. And he's a lawyer, actually. And so ultimately he got an open surgery and we had to take it out. So the point of this is we're treating these patients, we're fixing the immediate problems, but they have a whole series of long-term problems. And I think that we can do better in this. You can imagine these complex dynamics are even more difficult with dissections. And these are dissections which we're treating ever more with thoracic stent grafts. These dissections have serious long-term morbidity and mortality. We've improved them significantly with stents, but there's still a lot of work. And I think the reason is all this is a very dynamic, moving environment. You can see the ascending aorta, this flap is flapping back and forth. The descending aorta is moving just a little bit. And these stents are just simple tubes. I think we can make them better, and I think we can understand the environment a little bit better. This is a dissection patient. Same thing. Just you can see how this flap kind of moves back and forth. It's a dynamic environment for these patients. And really, you're used to looking at static CAT scans. You see a simple image, but in reality, it's not a simple image. There's blood flowing in there, and the blood isn't laminar necessarily, and the blood is going in these branches. The blood catches up on some of these stents. None of this has been considered when they've designed these stents. But maybe in the long run, we'll change the design characteristics of the stents. This is an MR showing the blood flow, right? This is a normal, healthy 20-some-year-old student, right? Normal. But these kind of flow dynamics are very different in patients with aneurysms, and we're not even paying any attention to it. So we're using these stents. We're using them for these thoracic catastrophes, and we have no idea if they work. So we decided to first look in the literature. Do they work? So TEVAR, or thoracic endovascular aneurysm repair, is being used more and more for these catastrophes. So we looked in the literature. If you look at the years, just take a look at yellow. In 1996 to 1999, there are 0 TEVARs being used for these catastrophes. In 2005 to 2009, it's 90%. It happened that fast. In a period of basically 10 years, it went from 0 to almost 100%. It's completely changed with no data. Well, we looked at the data, and in fact, they do better. Our intuition is right, right? So if you look at the 30-day mortality rate for a ruptured thoracic aneurysm, these are the ones that make it to the operating room. 30% die if they get an open operation versus 19% if they get an endovascular operation. So we're doing better, at least in the literature. So we decided to look at our own data. We looked at the New York State data. Again, same kind of information. TEVAR is in red, endovascular is in red. Before 2005, nobody in New York State, where Paul and I used to work, got a TEVAR for a ruptured thoracic aneurysm. After 2005, they've taken off, and if you look at 2010, 2012, it's essentially 100%. And the mortality is much improved if you get a TEVAR. So what we're doing, at least from our own opinion, has been supported by retrospective analysis of all the ruptured thoracic aneurysms in New York State. It's been supported by all the data in the literature, so it seems reasonable. But we still have a lot of secondary interventions. Again, the same point I'm trying to make. We save their life, and now we create another problem. So I have a theory about this, and I think that we're looking at these patients in the wrong way. I think we need to think about the sizing of these stent grafts in a different way. So we know when patients come in with ruptured aneurysms, they lost a lot of blood. Sometimes they lose half of their blood volume or 2/3 of their blood volume. When you lose a lot of blood, obviously you're hypotensive. When we were sewing in the grafts with 3-O-proline, it didn't matter. But now we're putting in these stents. So how much do they change? Well, we looked at all the patients that came into Yale that had massive blood loss, had a CAT scan when they were hypotensive, and then had a CAT scan once that they were saved and were normotensive, right? Obviously, we excluded the ones that died. So you can see that in general, all the trauma patients, and these weren't just patients with ruptured aneurysms, these were patients that came in shot in the femoral vessels or whatever caused them to lose their blood, not necessarily just ruptured aneurysms. You can see that their thoracic aorta, where we put these stents, changes by about 13%. Generally speaking, when we were training, we decided to oversize our stent grafts to hold them in place by 10%. So you can imagine if we're putting in a 10% oversized stent graft in a hypotensive patient, we size them based on that initial CAT scan when they're hypotensive. And then we resuscitate them and their aorta expands 13–15%, there could be a gap between the walls, and those things can move, can migrate, or have endoleaks. At least that's the theory. So we decided to do it in a little bit more controlled fashion. Now, I have here a pig which I'm operating on. No, that's the pig, that's me, all right? And we decided to take these pigs, we drop their blood pressure, we remove their blood, 40% of their circulating volume, which is consistent with a ruptured thoracic aneurysm, sized them with intravascular IVUS, deployed an intravascular stent, and then resuscitated them and see what happens to the sizes. Well, just like our trauma patients, as you would expect, as they lose blood, their diameter of the aorta changes. It's just common sense, but nobody looked at it. How much does it change? It changes by, when you lose 40% of your blood in a healthy pig, by almost 30%. It's 30% smaller, right? Now, I'm not trying to make a disparaging remark, but the simple fact is 22 and 24 and 28-year-old motorcycle people that wreck their cars and rupture their aorta, or wreck their motorcycles and rupture their aorta, have aortas that are very similar to pigs. That's just a fact. So I suspect that their thoracic aorta diminishes about 30%. And we treat these now 100% with TVARs, thoracic endovascular aneurysm repairs. So here's the idea, right? Imagine this is a 31-year-old motorcycle rider on 95, wrecks his car and tears his aorta. This is his aorta. This is the hole in his aorta, and that's the size. Used to be we just stitched it up, put in an interposition graft, no more. Now we put in a stent graft and reline it, like putting an inner tube inside of a tire, right? We reline it, we cover the hole. We make the perfect size. We put in the inner tube, we put in the stent graft, which is this white thing. We cover the hole, we save their life. We feel great. They do well. We resuscitate them up. Their blood pressure increases, their aorta increases by 30%. Now this stent is too small for the aorta. It moves, and there's a little bit of a leak that comes in here. This is the endoleak. This is the 17% type 1 endoleak that we see in these patients. Right? So I think that that's what's happening, and you can see it in this very poor image. So here's a pig's aorta. Imagine that the white arrow is the aorta when they've lost 40% of their blood. The black arrow is the stent graft, which is right up against it. Okay, just take my word for this. Now take a look at this picture. Here's the white arrow, here's the wall of the aorta. There's the black arrow, that's the stent graft, and you can see the yellow arrow is pointing to a gap between the two. That's after we resuscitated them, right? That happens in a pig, and it happens in a human. So we've changed our practice, right? So probably you have someone like an aorta like this, which is full of calcium. They probably don't change that much. But a young, healthy trauma patient, they probably change quite a bit. So we've changed our practice. Now, when a patient comes in and they're hypotensive, I use a rule of thumb, I just oversize by 30%, maybe 40%. It depends on how hypotensive they are at the time. I use a lot of intravascular ultrasound, so we resuscitate them and we do sizing on the fly. So we size it based when their aorta is their blood pressure is 120, not on the CAT scan when their blood pressure was 80. I think this probably decreases our secondary intervention rate. I think it's better for the patients, right? And I think we're going to do better in the long run. So the point of all of this is that vascular surgery is very different than it was 10 years ago. Imaging is critical, and I'm going to close with this one video. If you don't mind, Paul, could you just click on that video if it works? Just click right there. This is just to show you that vascular surgery is different and imaging is critical.